Welcome to the Neuroveda podcast for complex health. We feature expert guests who dive into ancient and cutting-edge understandings of health and disease. These conversations are about food, lifestyle, and medicine just as much about nature, culture, and politics. I'm Jillian Ehrlich, family nurse practitioner, certified in Ayurveda and functional medicine, coming to you from our clinic, Neuroveda Health, in Seattle, Washington. Remember that nothing we discuss today should be considered medical advice. This is all pontification for education and interest and curiosity. And today I'm thrilled about our guest. Dr. Ferdinand Hui is a CAST certified neurointerventional surgeon, CAST being the Committee on Advanced Subspecialty Training. He trained with Dr. Jacques Dion at Emory University, one of the pioneers in the field of neuroendovascular surgery. And this is a medical subspecialty composed of neurology, radiology, and surgery, specializing in minimally invasive image-based technologies and procedures used in the diagnosis of and treatment of the diseases of the head, neck, and spine. We've talked a little bit with Dr. Hui that we're going to go beyond the head, neck, and spine today. And so a lot of this will be, conjecture and philosophical, neurological discussion. Dr. Hui received his undergraduate and medical training at the University of Virginia and is an internationally recognized expert in the treatment of stroke with over 110 peer-reviewed publications and book chapters. He's also a delightful human being. This is what I've learned about him, and says of his work, quote, "Nothing brings me more joy than being able to work with a patient to help them heal and bring them back to the people they love." Dr. Hui is also very active in research, community programs, and health startup space to support continued care and innovation in cerebrovascular diseases. Dr. Hui, welcome. We're so happy to have you.
I'm going to make a joke, not even a full joke, but you found a very old bio of me. I'm now over 210 page papers, so it is what
Oh,
it is.
that is, it's multiplying, exponentially multiplying. Well, it's good. I mean, you're active in this space. And so this is a great starting for a conversation because there is so much that and when we think about what do people, what does our audience need to know about these topics, like you're a perfect person to kind of tell some stories here today. So
All right.
being with us. Let's start out by defining for us. There's all these terms: neurointerventional surgery, neuroendovascular surgery, interventional neuroradiology, endovascular neurosurgery, interventional neurology. Why are there so many words? Why are there so many words for this? What's the crux here, and what are the differences?
Why are there so many words? Politics. What do we actually do? It is minimally invasive surgery of the blood vessels and spine. I think it's going to continue to evolve. The current preferred term by most of us is neurointerventional surgery. That the key society is the Society for Society of Neurointerventional Surgery. Uh, we train people from neurosurgery, neurology, as well as neuroradiology, and we practice treatment of strokes, aneurysms, and we're expanding to other things, much like cardiology. Interventional cardiology expanded from treating heart attacks to treating all sorts of things that we originally thought were only addressable by open surgery. So yes, there's a lot of evolution, and I think in 10 years, it'll look very different from what it looks like now.
And so at the crux, just, at the most basic level, you're doing surgical procedures with imaging equipment. So you're going in with tools as guided by imaging to kind of get you to your right areas. Is that right?
That's correct. So we're using, at this point, X-rays, but is research to try to use MR as guidance. But right now we're using X-ray technology, and we basically do plumbing for the majority of our procedures. There's some of it, it's needle-based, but I would say 90% of our society uses tubes and wires and does rotor-rooter techniques to get to the target. And we either plug leaks or unclog clogs. So ischemic strokes are clogged pipes in your brain. And so we will pull out the clot just like a plumber. And then the other side is when there's a leak, you're bleeding into your brain, we plug the leak before it kills you. So either we're plugging a leak that's killing you or unclogging a clog that's killing you. And that is our general scope of work. And there's a lot of ways your brain and your blood vessels of your brain can kill you.
Okay, perfect. That's great. That's great. So let's back up one step and just talk about like our blood vessels. Can you talk to us a little bit about our blood vessels, the vasculature of the body, and then what it does kind of between the heart and the top of your head?
Sure. So everybody intuitively understands arteries. In fact, sometimes when we talk about arteries, we use the word vein. We're still talking about arteries. Um, the heart is the central pump. It is the driver of arterial blood flow. It takes fresh blood that has been oxygenated by contact with your lungs, takes raw materials, sugars, nutrients, and delivers it to your entire body, to all the organs that use it. So that would be the arterial side. We've been studying this very well for the last 150, 200 years. And while we don't know everything, we understand it moderately well.
Mhm.
The other side of the heart, which uh, we'll talk a bit about today, we don't study very well. We know that veins are there. Veins carry up to 70% of your total blood volume. They're probably around 3 times by length as long as your artery. So there's a lot more of them, but they're also a lot less systematic. It's a lot less predictable, a huge amount of variability. And so we've really struggled as a scientific community to study veins. I think that's changing. We're starting to pay a lot of attention to it. So that's actually a lot of where my research is now, looking at the venous system of the brain, what it does, how it can kill you. And we're make a small plug. We are going to be releasing a book. It's going to be very nerdy, called The Other Side of the Heart, looking at the veins of the brain in volume 1, and then the veins of the rest of the body, volume 2. Hopefully in the next year to 2 years, that'll be out for so that science and the occasional patient can read it. Last comment is there is actually no book on this topic out available in the press right
Wow.
now in English. So we're looking forward to putting the first version out.
Oh my God, it's fantastic. And it's very true. So, and is it true that arteries have muscle associated with them and that veins are more passive? Is that true?
That's exactly right. The arteries taper, and this is a method for your body to maintain pressure because you need to be able to drive fresh blood out of the blood vessel and into the organs that need the blood. So arteries have muscles to maintain muscle tension and pressure inside the artery and continue to drive arterial blood flow into your tissues. So yeah, they have 3 layers, the adventitia, media, and intima.
Mhm.
And inside that is a thing called the endothelium, and that is the grease, as it were, the lubrication that allows your blood to flow well, and it's also a protective layer so that your blood doesn't tear up the pipes that carry it.
Got it. Got it. And how, am I remembering correctly that that endothelial layer is very thin? Is that right?
It's actually a lot thicker than people imagine.
Oh,
So
right.
when you see pictures in textbooks, they draw it as very thin.
Uh-huh.
Uh, and when you
That's
look
right.
at it under an electron microscope, it's actually a lot thicker. So think about a layer of kelp at the bottom of a moderately deep seabed. So you can see this kelp waving under the ocean currents. That's
Uh-huh.
probably a more accurate look at what that endothelial layer looks like, the protective layer on the inside of your intima.
And that's for the arteries only, or that's veins also?
That is what's in the arteries. We don't actually know the veins very well. So that is active research.
Whoa, that's phenomenal. And so um, arteries essentially take blood from the heart to the body, and then those arteries essentially taper down, and then they transition to veins either through organs or through small capillary beds. Is that right?
I think, I guess the best way to look at it is um, the arteries branch and branch and branch again until they're capillaries. And the capillaries then kind of end, they perfuse the body or they perfuse the organ. On the other side, the spent blood recollects into little venules that gradually coalesce, kind of like a riverbed, the tributaries to a river. And
Mhm.
these little streams coalesce into the veins and dump into the large veins that eventually carry the blood back to the heart. Now, you're right, there are no muscles to these veins, so everything that drives your venous blood and your interstitial fluid back to the body is passive. There are no active drivers within the lymphatics or your veins that drive. So you have to rely on either gravity, muscle, or as you guys know, massage to try to get the stuff out of your tissues back towards your heart.
Fascinating. It seems like that's a system. It's surprising that evolution chose that system a little bit. Like these will just passively, there's so much investment in the arteries and getting oxygenated blood to the tissues, and then it's so passive to come back. So venous, like what are they called? Varicose veins. Like people might know varicose veins, or if you get your blood drawn, you get a needle put into the vein that's in your antecubital, like in your arm, in your inner elbow. That's how we can kind of think about veins.
Yeah.
Okay, so then talk to us about like what does the circulation of the brain look like? Like what happens in the neck and the brain?
Can I just say it's complicated and quit? No.
And that's a wrap.
So I'm gonna do it in a comic sort of way, because actually you think about common culture, vernacular culture, we are aware of veins, go for the jugular.
Yeah.
And that's in common parlance. And we know that if you cut the jugular, or at least we assume that bad things happen to you. And it's
Huh?
probably true. Cutting the carotid will kill you faster, by the way, but cutting the jugular isn't great either.
As you were saying that, I was thinking nobody says like go for the carotid, but that would be way more effective. But yeah.
I'm not sure way more effective, but more effective, yes. But going for the jugular is indeed the primary venous drainage for the brain. So the two jugular veins, especially, are huge conduits of blood flow. The brain is about 2% of your body by weight, but it demands 12 to 20% of your blood flow. So it's a very, very blood greedy organ. And if you think about how much energy your brain can actually use, you think about the average chess master, they eat a tremendous amount. They sit there thinking, burn calories, and stay relatively thin, just thinking. So your brain can actually expend a tremendous amount of energy. And for that, it needs a tremendous amount of blood flow. And so that blood flow, for every ounce of blood that goes in, an ounce of blood needs to come out. So you're very dependent on an adequate venous drainage. So the jugular veins do the heavy lifting in general. They're wide open when you're laying down. When you stand up, they tend to collapse. And we still haven't established exactly the mechanisms for that. But in ultrasound studies, we have shown that when people stand, the majority of the blood flow that is measurable seems to be in and around the spine, and less of it through the jugular veins. That will be a topic of further study in the future, but in any case, that's where we are right now.
Fascinating. And so when you're going and doing your rotor-rootering, are you like, where are you in the brain, or are you always in arteries, veins? Like, where are you?
Well, most of our technology is arterial focused. So the things that establish the field are either treating strokes, where you have a blocked artery to the brain and your brain is dying. And the other big treatments we have that really establish the field is treatment of aneurysms. So the dreaded brain aneurysm kills you at around 30 to 50% of the time before you get to the hospital. And if you survive that, there's about a 30 to 50% chance that you have permanent neurological injury. And it can take 2, 3, 4 weeks of your life and you won't remember it. So aneurysms are pretty impressive in terms of a way to kill you fast. This is not a joke. If you think about the things that kill you really, really fast, they're all vascular. If you have a brain aneurysm, if you have a heart attack, if you have a stroke, if you have a pulmonary embolism, if your aorta ruptures, probably the top 5 things that can kill you within a couple hours are all blood vessel related. Cancer kills you slow.
And in that list, like some of the things that you mentioned are hemorrhagic, or are like breaks in blood vessels that release the blood, so then you can't capture it anymore to feed organs. And some of the things that you mentioned are obstructions or clots.
So when you bleed so let's talk about this back in the plumbing framework. So leaks and clogs. So the leaks kill you several ways. One that you mentioned is lack of blood flow to the organ. That's true, but The reality is it's probably more, you've got fresh arterial blood with oxygen in it. There's a lot of oxidative damage. There's a lot of free radicals. Pressure. You have arterial blood in place it's not supposed to be. It expands. It crushes the organ. And then once the pressure in this area exceeds or is similar to your systolic pressure, there's no longer blood flowing in. It's not so much it's diverting blood, it's crushing the organ such that it no longer can function. So a bleed can kill you by virtue of its pressure, of the chemical reactions from the oxidative stress. And so, an aortic rupture kills you 50% of the time. A brain aneurysm kills you 50% of the time. A cardiac rupture will kill you nearly 100% of the time. If you rupture a femoral artery or a brachial artery, probably in combat, in warfare, or an accident, it can kill you very rapidly. So blood loss. Excuse me. The other side, ischemia, is different because it kills an organ, but it doesn't kill the rest of the body as fast. So to give you an example, if you block blood flow to half your brain, within maybe an hour, 2 hours, the brain may be permanently dead. And then it will kill, I apologize, something went in my throat. So that the brain may defunctionalize, the heart may defunctionalize, the organ may defunctionalize. But in the case of the brain, half of the brain is dead, but it hasn't killed you by killing the rest of you. It's just that brain will never come back. After that, the chemical reactions and the swelling, the brain can swell and then crush the other side. Now, once you've crushed the other side, now both sides of your brain are dead, and that can be, formal brain death. It can, have knock-on effects on your heart. If your heart has a big ischemic injury, it may kill you instantly because your heart stops, but often it impairs your heart's ability to beat well. And now over the next, however many months, years of your life, you're now impaired. Your blood doesn't flow as well. Your health is worse. Your muscles atrophy. So ischemia can kill you that way. Same thing with your liver or your kidneys. Ischemia kills chunks of tissue, but it may not actually end you unless it's done enough ischemic injury to destroy the machine of your body sufficiently that you can't function. So I hope that helps kind of.
Yes. So that is a great overview, because then we can really get into the weeds of like coagulation disorders. And so, or heart failure where the pump isn't even pumping, or, there's all these other elements that then ways in which things really get into the nitty gritty about how things can either go right or go wrong. Is that right?
Absolutely.
Okay. Okay, so now we know about these components. And when you're talking about aneurysm, you're really talking about, can you talk a little bit more about kind of how an aneurysm happens?
Sure. So aneurysms are divided into two gross groups. One would be a true aneurysm, and the other is a false aneurysm or pseudoaneurysm. A true aneurysm contains all of the muscle layers that we talked about, the intima, media, and adventitia. A pseudoaneurysm is when the aneurysm only contains a fraction of those. So this happens when you tear a blood vessel. So a torn blood vessel may only have one or two intact layers, and now you've got a pouch, a little side wall of this bubble on an aneurysm, on a blood vessel wall, and that thing is now growing. The larger it gets, the more unstable, because it's the shear, the forces on that wall increase as it's a matter of physics. The same amount of pressure, the larger the diameter, the more shear stress on the wall. And beyond that, aneurysm walls are normally not healthy tissue. There's a lot of data to suggest that the inciting event for an aneurysm formation is either a combination of atherosclerosis plus abnormal tissue shear that incites this thing. The aneurysm will have macrophages, inflammatory cells, superoxide dismutase. There's things going on that are unhealthy for the actual cells in the tissue.
Mhm.
There's lots of data to show that there's cell death, that apoptosis, organized cell killing when aneurysms rupture. So they get to a critical stage of physiology, and then you get this rapid breakdown of whatsoever's left in the aneurysm, and that's what precedes the actual rupture. And some of this is driven by the shear, because you've got this pulse pounding heartbeat driving high pressure blood into a weak spot. That's literally what's going on. Um, and so that's kind of aneurysms in a nutshell.
So if we were going to say, so now we've kind of described these like emergency conditions, right? These emergency and potentially fatal conditions like stroke, heart attack, or myocardial infarction, or aneurysm. Like before that, how do we think about, and I know that you're a surgeon, so you're not like necessarily on the preventative side. But I'm just curious if you wanted to like wax poetic about what your thoughts are about like what happens before, what happens in the 6 months to 1 year to 5 to 10 years before a person gets to that emergency state. Like what's going right or what might be going wrong in their vasculature, and how do we think about how we can act on that?
I think you should act at birth. And I absolutely all for preventive
Uh-huh.
medicine. The American medical system may really reward surgery, but the reality is what humanity needs is prevention. And
Yeah.
so and prevention is may even be better conceptualized as living well or longevity, right? Longevity medicine really starts at birth. You want to prevent everything. And what does preventing everything mean? It means healthy living from the start. So we all know this, what not to eat. And I just ate a McDonald's breakfast, so clearly I'm not very good at it. Um, but low salt, or rather a right amount of salt, avoiding fried foods, or avoiding highly inflammatory foods, keeping your blood pressure low, because the high blood pressure adds more strain to all your blood vessels. Smoking or vaping, nicotine constricts the blood vessels that supply your blood vessels. So
Mhm.
that's why when you smoke, your wounds don't heal well. In fact, surgeons don't like operating on smokers that are smoking because your wounds don't heal. And so if you injure your blood vessel when you're smoking, your blood vessel doesn't have a very good blood supply, so it tends to not heal as well. So we're injuring our blood vessels and we're injuring our body all the time. So when we have drugs and lifestyles that impair our body's ability to heal, we're accumulating chronic damage at a faster rate than someone else.
Got it. Got it. And so, it's kind of like I think a lot of these conditions and a lot of the chronic conditions that we see, chronic and complex health cases that we see in our clinic are kind of in the middle, right? So, there's kind of like light and there's dark, and then there's like this kind of dim place in between. And so sometimes I think about a lot of conditions that lower flow, but aren't necessarily hemorrhagic, aren't necessarily a full clot, but they're kind of these low flow states. And I'm wondering if you can talk a little bit about some of the things like Eagle syndrome or CCI, craniocervical instability, or things that might interrupt enough flow, but not enough that you're actually in the emergency room seeing you as a patient.
And Western medicine is horrible about these low flow states because they don't meet what we've studied.
Uh-huh.
But let's just do a thought experiment. If your cell phone runs on 110 volt energy, which is what it does in America, and you give it less energy than it needs in the plug, it doesn't even charge particularly well. Uh,
Mhm.
and so that would be, I think, a good example of, if any of you have, and I'm sure you do, know somebody who has congestive heart failure or low output heart, they don't think very well. They can't do very much. They're kind of like a low energy cell phone. You can't do very much with it. And we've seen that when you improve the heart function, people perk up.
Mhm.
What a shocker. I mean, we who would have imagined that your primary pump is doing badly, that the whole body doesn't do well, and if you make it better, what a thought. And so I think that's a good proxy to start thinking about what low flow or impaired flow states look like. If you can't get blood, healthy arterial blood to your lungs, it can't oxygenate well. If you can't oxygenate it well and you're not pumping well, you're taking poorly oxygenated, and frankly, it's more than that. Oxygen is just part of it. If you're trying to move blood in and out of your gut to take the nutrients out of your food, bring it to your liver, process it, get it ready for consumption for the rest of your body. The reality of nothing works. It's like having a broken postal system or congested roads. If our roads were all working at half capacity, you can imagine our entire country would be paralyzed. So if our pump is working at half capacity, our entire body is working in low brownout conditions. So it's not shocking at all. I would say that the other piece, and this gets to my areas of interest, we don't understand veins well. We don't study it in Western medicine. But if you don't take out your trash, or the trash collection system isn't coming and picking up your trash, everybody in your house will get angry. It will start to smell. People will start getting sick. Bad things happen. And we all know what happens when you plug up your toilet. Let's just say nothing will be happy in a house where the toilets are clogged.
Or
And,
only half flushing. Like,
or even half flushing. Yeah.
yeah. And so can we talk a little bit about long COVID? Can we talk a little bit about what COVID does in our blood vessels?
So let's talk about, I'm going to start with what we know, and
Mhm.
then we're going to talk about what we need to know. And then we're going to talk about neuro long COVID, what we found and what we need to understand. So one, COVID, and I'm not going to talk about any theories on where it came from or anything like that, but COVID, when it hit us in 2019, we saw a lot of people clot, and they would do terrible damage to their muscles, to their lungs, and they would have little ischemic injuries all over the place. We eventually realized that the spike protein of COVID, the thing that gets it into your system, that allows it to attach to a blood vessel wall, burrow out, and then find cells in which it can infect and reproduce. You had a thing called a spike protein, and this spike protein allows the COVID virus to attach itself to your endothelium, climb down the glycocalyx, just literally Jack and the Beanstalk, go to an ACE2 receptor. It uses the ACE2 receptor to get inside the cell, and then it can breed and reproduce. And this spike protein causes a shedding where you lose your endothelial layer, or at least lose a substantial amount. And if you lose your endothelial layer, you now have a raw exposed blood vessel. It doesn't have its protective coating, and most likely this creates a hyperthrombotic or a prothrombotic state. So you start clotting the inside of your own blood vessel because it no longer looks like a blood vessel. So we think that that's part of how long COVID, or rather COVID version 19, caused so many strokes, so many heart attacks, so many pulmonary infarctions, ischemic injury to the lungs. And a lot of people needed lung transplants because their lungs were so damaged by COVID. The more recent versions of COVID don't seem to do this as aggressively. We don't hear about as many people having horrible strokes and dead lung. And that may be, this is an aside, but we have evolved as a population to coexist with many viri. What's a successful virus? A successful virus infects everyone, reproduces at lib freely, liberally, causes barely any damage to its hosts, because if you kill your host, you can't breed. So things like the common cold, things like Epstein-Barr virus, almost 100% of our population have Epstein-Barr virus living in us. That's a successful virus. It doesn't kill anybody, or kills a couple of people, and it lives with us, and we don't really mind it. We don't try to eradicate it because, it doesn't do that badly. This virus actually has a complete copy of IL-10, interleukin 10, which is our identified friend and foe system for our own cells. So when your cells find a cell with Epstein-Barr in it, it's infected, but it flashes the IL-10 and says, yo, I'm one of you. So you
Hmm.
don't kill it. And so
Hmm.
that's why Epstein-Barr virus is essentially not eliminatable in a human population. It's just literally evolved as almost an internal viral
Hmm.
thing,
Hmm.
chicken pox. So anyway, I would say that we're anticipating, I hope I'm not too fringe on this, COVID will just become another one of these things that,
Hmm.
like Epstein-Barr, like chickenpox, like herpes, it's here forever, and it will get more and more mild.
Hmm. And we've had coronaviruses forever. So COVID-19 is just another version of this coronavirus.
Yep.
Have
So to
that.
get back to long COVID,
Mhm.
there were initially in the scientific community, there's a question of, is long COVID real? You have patients that we can't see anything wrong with them, but are telling us that A, B, and C, X, Y, and Z feel wrong, and whatever it is. And gradually there's acceptance that neurological impairment is a part of this thing we call neuro long COVID, which is now becoming the majority of the long COVID syndromes. We used to see a lot of muscle pain. We used to see a lot of dyspnea. It's still there, but it's becoming less and less of the phenotype that we see in long COVID patients, more and more of these cognitive impairments, dysautonomia. Um, we originally were looking for something similar to what we saw in HIV, which is to say that HIV viri are hanging out in your brain and alive, not doing a ton, but still there, a reservoir effect. We're not seeing that, at least presently, in the neuro long COVID research. We don't see that there's an active infection. We don't see that there's a passive infection. So whatever the mechanism for neuro long COVID is, it is not well understood or accepted at this point. So expect to see this continue. The last time we had a new virus enter our population like this is probably about 100 years ago. So, and we didn't have the biomedical science to study it. So we're going to be studying COVID's effects for the next 20, 50 years. So stay tuned. Yeah. Oh, so sorry. There's an upcoming paper that we are releasing
Mhm.
looking at neuro-long COVID symptoms versus venous congestion symptoms. And there's a lot of overlap. So what we're expecting to see over the next 20 years, our group, now, again, we could be wrong, but we're expecting to see that there's a mechanistic similarities, because why would you have such similar symptoms if there aren't some similarities in the mechanisms? So what I'm hoping to see is that, or what I'm expecting to see is endothelial injury may be a chronic problem in neuro long COVID. And therefore, and how does this work? If you have a endothelial injury, your blood doesn't flow as well inside your blood vessels because it's like having a unpaved road. You cannot go that fast on a dirt road. And so it's possible that COVID has unpaved your blood vessels, and now your blood isn't flowing as well in your arteries and possibly veins as well.
And so how would you like, so two questions. One is, let's say that spike protein is the, oh God, what are they called? That essentially the jackhammers that kind of route out the pavement. So let's say that the spike protein has kind of caused that. Why doesn't your body lay down new
We don't
as
know.
okay.
We'll find out. That's what the research is for. This is you know, you and I, you're living in functional and Ayurvedic. I'm living in Western medicine. The strength of Western medicine is we do these things very, very mechanically on a biomechanical basis. We sometimes miss the big picture, but we're very, very good at the very small picture. So what we need to study is what are one is endothelial stripping still something that's going on with long COVID? Is endothelial stripping not only ongoing, but is the repair mechanism for some reason impaired?
Mhm.
Uh, if those things are true, then the questions that arise are, how do you fix the endothelium? How do you prevent endothelial injury, and so on and so forth? And then, of course, we need to find out whether the endothelial repair improves the outcomes for patients with neuro-long COVID. So that's a long pathway, but those are
Yeah.
the things that we hope to work on in the next decade.
And so so one of the things that I know that you and I have talked about at other times is kind of the potential amelioration of this mechanism with anticoagulants. Like there's a lot of people in the long COVID world that are talking about various anticoagulants from pharmaceuticals to lumbrokinase to to Plavix. And so
We don't know, but I think what we're all approaching the problem, the same theoretical problem from different angles. So if your endothelium is stripped and you don't flow as well, you're going to form microclots and you're going to have relatively viscous blood. And so you thin the blood and you're opposing the very thing that this naked endothelium does. The other piece of this is it's possible that there's an anatomic component. As you know, I'm very interested in venous strictures, so compressions of veins. If you have narrowed veins to start with, you're going to be more vulnerable to an endothelial stripping event because you're already impaired. You just don't feel it. And then you get really impaired. Maybe that's what's going on. But we've got a lot of work to do. So the paper that we just released was a series of neuro-long COVID patients that we treated while I was at Hopkins. And we found that a number of them had a jugular venous stenosis. And their pressures, their intracranial pressures were high. They had so many of the features we see in idiopathic intracranial hypertension, which is a term I hate. We're going to work very hard in getting rid of that term in the future. But the bottom line for this is these patients literally went to the ER, got lumbar punctures, had very high opening pressures, and were told that's got to be an error. This doesn't make any sense.
Wow.
Yeah, don't worry about that. That's not what's going on.
Mm-hmm.
And then we redo these tests. They still have pressure. And there are papers that are now coming out post-COVID idiopathic intracranial hypertension. And I'm just going to say it here. Again, hate that term. I would rather the old German terms or the old, and we're going to try to work on some new terms. But yeah, so we see this crossover. That's what this paper is about. And hopefully we'll get some more light shed on this over the next years.
And do we have any sense, so what would be potentially leading to venous stenosis that would result in the...
So the venous stenosis, I would say, is probably a risk factor or, something you're born with or you develop early in life. And if you have good enough collaterals, if you have good compensating mechanism, it's kind of like living in a mountain with a septic tank and, you've got great conditions. But with a septic tank, if it gets overflow, you need to get it cleaned out. And you've got this vulnerability that somebody who's living on a industrial urban scale sewage system doesn't worry about nearly as much. So if you have a bony constriction around your jugular veins, you're going to have to develop methods of draining your brain, when you don't have great jugular veins. So I would say that this is kind of like having flat feet, or, you happen to have tendons for your muscles that are attached in a less advantageous position than somebody else. So your muscles may be big, but you're actually less strong because the physics of your joints aren't as favorable as somebody else. So this is a thing you've got. And then if you have an inflammatory problem, like COVID, or you get in a car accident or something else occurs, you go from a vulnerability to screwed. And so we've certainly seen that patients that have had a clotting event or drugs that cause clotting or a car accident, which just changes their anatomy, then they go from they're okay to highly, highly dysfunctional. So I think that's what's going on. And COVID is one of those things that pushes you over the edge. That's what I think.
There's actually a Sanskrit term. I think it's namita for the completing action. It's essentially the akin of the straw that breaks the camel's back, or like the cigarette that gives you lung cancer. And so there's a concept in etiologic terms of like, this is the completing action. So this trigger that tips the scales. Do we know, what are the differences between the epithelium of the veins versus arteries in the body?
Wait another year or two. I've got one of our colleagues is currently working on defining that.
Okay. And so, is there anything in any medical system, I mean, is there anything in Western medicine that we know as a treatment essentially to heal epithelial linings of blood vessels?
Nope, but we're working on that too.
Okay. We're gonna have to do a recap in another, a 2026 recap.
If you're interested, one of my colleagues here is a Danish-trained PhD, a world-renowned glycobiologist who does exactly that. His space and his dad's space is endothelium. So if
Oh,
you'd like to bring him back, he's wonderful and he's got some stories you're going to love. I don't want to steal any of his thunder, but if you're interested in talking to Thomas Mandel Clausen,
huh?
uh,
Oh,
you'll enjoy him very much.
this is so interesting. And so, okay, so we've really run the gamut. We've talked a lot about flow. We've talked about long COVID. We've talked about veins and what we don't know about them. We've talked about arteries and what we do know about them. Um, Anything else that you want to say or go into about these like brownout conditions? Just because I feel like that's probably the majority. It's a smaller percentage of people, although it's a larger percentage of patients because we actually see them. They actually present with signs and symptoms of stroke, MI, you know, PE, but this larger population is probably just like living in the dim.
Yep.
So
So I
how do
would
we,
say sorry, I cut you off. Go finish, please.
I was just going to say, how do we alert people that their brain fog might be this like low flow state, or how do we evaluate that or treat that?
I'd say there are three problems here. One is even if we identify them, we don't have enough people to manage them right now. That it's
Yeah.
just our healthcare system is so busy, understaffed, and under-resourced to manage what we already know about. And as an emerging disease state, we have a lot of work to do to get enough people that it can actually manage patients with brain fog. There's a lot of people with brain fog.
Yep.
And to my knowledge, you're one of the few places that are interested in them. And I've actually thought a lot about starting a brain fog clinic because that's what I'm interested in.
Yeah.
And yeah, so maybe we partner one day. But in any case, the brain fog problem, how do you identify? I think it's going to take a lot of the data from Western medicine is that when we make a discovery, it takes 20 years before it's fully implemented. That's a long time for millions of people with brain fog. I suspect it's millions. So if it's millions of people with brain fog and we have maybe 10 people interested in the country in brain fog, numbers don't add up. So we're going to have to figure out how to accelerate this in the next years. Second, we need to develop one, identification methods, two, screening/identification methods, two, management paradigms, platforms to actually see them. And third, we need effective therapies. Right now, we don't have effective therapies. We have candidate therapies that we're trying to validate.
Mhm.
So I think that all of those things need to be worked out at the same time. It would be great if we could do it the nice scientific method, develop the treatment first, then start looking for the patients. But that's 20 years from now. So I think we're going to have to be developing all of these things kind of at the same time. Some of the work will be at the bedside, trying out new physiotherapies, new non-invasive techniques. We're working on a paper right now to talk about the things that we've seen that have some signal, have some benefit. Would love to see what works in your hands. We need to be working on the surgical techniques and validating them in methods that the Western medicine accepts as proof. And then we're going to need to figure out how to train enough people to do them. So those are all the things that in the vein space that we need. I will say this, in general, people, even the people that treat veins, by and large, except for a very small tip of the spear group, they don't recognize the symptoms. So I'm just going to run through some of the symptoms, and actually we'll send you a recognition sheet. We're working on a severity scale right now, our team, and maybe you guys will find it useful. But the big ones that we think for the brain and the head and neck matter. So head pressure. People have headaches, and often people will tell you, I have a headache. And then you go, what kind of headache? And they say, well, they told me it's a migraine. And then you say, so what does that mean? Well, I've got, migraine headaches. And you're like, what does that mean? So I try to push people to actually describe the headache. And if I hear the words pressure, uh, and fullness and heaviness, I find that to be suggestive that maybe they can't clear their brain. I do think that visual blurring, pulsatile tinnitus, hearing your own heartbeat, that is a piece of it. A lot of the patients will feel pressure and fullness wherever they drain their brain. So whatever they're using in terms of their venous system to get blood out of their brain that shouldn't be there, they feel it there. So sometimes at the back of the neck, at the base of the skull, sometimes behind the eyes or in the sinuses. If you ever have a patient that says, well, I've got sinusitis, and then did you get surgery? Well, they didn't find anything, but they operated anyway. How do you feel now? I still have it. That would be a case of this sort of thing. What they're really doing is they're draining their blood behind their sinuses, and they feel their head is pissed off behind their sinuses, and they can't feel behind their sinuses, so they just say, my sinuses. And so the ENT surgeon that looks in their sinuses sees an empty sinus that looks okay, and then has to decide whether they operate or not operate, given that the patient says, I have sinus pressure, but I don't have sinusitis in the normal fashion. We see patients with vocal cord changes, voice changes. We see patients with chronic coughs. We see patients with neck pain and fullness, stiffness. It's basically, you name it, something that's going wrong in the head and neck. There's a situation where the veins are causing, or rather, a lack of adequate trash disposal is causing a problem.
Interesting. Interesting. That would be great to have. And we can definitely add that to this podcast information, is that list of symptoms. There's definitely a lot of work to be done in this area. And you're right. I do love brain fog patients. There are so many different things that can result in that symptom. So figuring out like which piece of the pie this, and how many different legs are in, different arenas for this one symptom, that would be fun to work on. Great. Okay, so I'm trying to think if there's any other questions that I have or that I think our audience will have acutely. Any final words for us about flow?
Thanks for reaching out. This is fun.
Yes, yay, good. I always think it's fun. The nerds unite. I'm into it. So thank you. Thank you so much for joining us.
All right. Well, till the next time.
Until the next time. And so we love that you've joined us today to discuss how to make our whole world medicine. We rise or fall together and are committed to sharing knowledge and insight that empower us and our communities towards greater health. Thank you for listening to the Nerveda podcast for complex health, and we'll see you next time.